The scaphoid is the most commonly fractured bone of the wrist. The bone itself sits at a 45-degree angle to the radius. It functions as a tie rod of the hand to the forearm at the radius itself. 80% of the bone is covered by articular cartilage, and there are no tendinous attachments there. However, there is very strong ligamentous support. As I mentioned, it is the most common fractured bone in the wrist and accounts for 70% of all carpal fractures. The peak incidence occurs somewhere between 12 and 15 years old. All fractures are intra-articular, with about 80% of them occurring at the waist of the scaphoid. The mechanism of injury for this type of fracture is hyperextension of the wrist, usually during a backward fall. However, I've also seen this during basketball when people stop themselves under the basket against the wall. But again, it's still a hyperextension of the wrist. There are three common stresses that usually occur across the scaphoid: a shear stress, rotational, and compression. When we have fractures, it's most typically due to the compression force. There are also different types of fractures that you'll see at the scaphoid, including transverse, a horizontal oblique, and a vertical oblique. The spot where the fracture occurs is very important because you can notice from this picture, you can see where the blood vessels are located. And if there is a fracture in a spot where blood supply is low, we can end up with a necrosis. Signs and symptoms include localized swelling in the anatomical snuff box. There will also be pain and point tenderness in the snuff box, especially on the floor, and it tends to be accentuated with ulnar deviation because of that concave convex roll of the bones. There will be anterior pain at the base of the thenar eminence if it is a tubercle fracture. The patient usually cannot support weight on that hand, and shaking hands, turning doorknobs, etc. are very painful and weak. Diagnosis generally is through an x-ray. However, it only picks up about 50% of the fractures. If the person has symptoms but the x-rays are initially negative, we usually will splint it as a fracture and then x-ray it again 10 to 14 days later. We can also use a bone scan, but typically an MRI will be the gold standard. The treatment is going to be either conservative or surgical. If we cast the person, they are going to be in a cast 6 to 8 weeks if it's a distal fracture or a waist fracture, but they could be in a cast 10 to 12 weeks if it's a proximal pole fracture. About 8% of scaphoid fractures become non-union fractures and require surgery. That surgery includes pinning and or bone grafts.